Practice Pros asked me to give a webinar regarding the PQRSs and the G codes. There's been quite a bit of questions regarding how we should be handling this through PT Practice Pro, and our practice has been working pretty diligently to make it a pretty seamless and easy integration for our therapists and our staff. And they asked me to come on and show you guys how we are doing this. So here this morning, which should only take us about a half an hour to get through this. And so for the overview, a lot of people have questions regarding our registry. Let me back up. Before I get started here, if you guys have any questions, please go ahead and write the questions in the chat box, and we'll get to those at the end of the webinar for you. Okay, so if you have any questions, please write those questions in the chat box. So on the overview, what we're going to be talking about today is we're going to be going through the registry versus claims reporting. So registry is photo. A lot of people have questions regarding photo. Some of you may be PTPN members and have to use photo. So I want to go over the pros and cons of using registry versus claims reporting. Then we're going to go over which G codes are the easiest to use for the reporting and what we're using in our practice for these reporting. We're going to go over how to set up these G codes. That'll be a little bit of a review if you've been on the Practice Pro webinars regarding this. And then, you know, how to make these evals automatically add the G codes for the HCFA forms through claims reporting. We're going to touch very briefly on severity codes. We haven't started the severity codes yet. I think those begin in July for everybody, so we're working through that currently. And then I'm going to go through an eval that we would do to show you how they automatically add and how easy it is when you're doing the claims reporting side of things. So on to photo. So one of our offices actually uses photo. We are a PTPN member in one of the offices, so we are reporting through photo. However, all of our offices, we are actually doing the claims reporting side of things. So you can actually still use photo, but you utilize claims reporting. And we really had a long discussion on if we were going to use registry or claims reporting. And when we were going through the entire scenarios in our heads, the biggest thing that stuck out is Medicare and the feds really want you to report. If you're using registry, you have to have 80% accuracy when you're reporting with registry. And that's a pretty high accuracy rate, especially when you're first implementing these programs. If you're a small practice, how do you keep track of if you're getting 80% reporting? So that was a really difficult thing to really look at and say, well, I think we could be successful in registry. When you're claims reporting, you only need 1 out of every 2 people accurate. And right there alone really tilted us towards the claims reporting through the HCFA forms side of things. The other thing we had problems with photo and a lot of the issues was photo causes a lot of double work. And I know PT Practice Pro is working on implementing some integration through photo, but it still creates more workload on your staff, which also causes increased costs. And as you know, we're not getting any higher payments or reimbursements from these insurance companies. So we really wanted to try to minimize the effect of costs on our business. And with photo as well, when we looked at it, in our opinion, it worsened the patient experience. We are in a business of having optimal patient experience. And when you increase intake times and you have an elderly patient or an older patient that doesn't understand how to use a computer system or an iPad, it really does worsen the patient experience for them, and in turn causes increased workload on the staff. You know, we first used photo through paper, and that caused too much work on our staff. The staff didn't enjoy it; they didn't like it at all. We had a hard time implementing and staying on top of the photo side of things. And then we went to a computer system, and patients just didn't understand the computer system. We thought, well, maybe the iPad would be easier because they just have to touch a screen. But we still have very similar problems that we had with computer systems. So we have really watered down our photo use in that office only, and we're doing the bare minimum that PTPN requires us to do at this time. and have just focused on the claims reporting, since we as a practice have already been utilizing our outcome measures, the Oswestry, the lower extremity functional scale, the dashes, those things we'd already been utilizing in our practice. So it didn't really affect us in that way. We just needed to make sure that PT Practice Pro software, when we recorded these outcome measures, they were just adding the G-codes on the HCFA forms, and we really didn't have any increased workload on our staff with that regard. So that is the main reason why we are really staying away from photo at this time in the registry side of things. 80% is a big pill to swallow. There are some practices that can't even get 80% of their patients in the door that are scheduled. So I don't know how they can expect to get 80% accuracy reporting to these through Medicare. So, and who wants to have their reimbursements decrease when they realize they hit 70%, and if they were claims reporting, they would have been just fine. So that is the reasons why we have gone strictly to claims reporting. And from here on out, we'll be discussing in this webinar how to get this report onto your HCFA forms, so now you can easily and effectively hit that 50% mark without even really any additional work at all. So going on to the G-codes we use in our practice, when you're doing claims reporting, there are 8 G-codes you can utilize. The medication is the big one we use, G8427. It is a one-time code. You report on your eval, and it's reported when you bill 97001, so the eval, or the 97003 if you have OTs and that. So remember, though, the key is that you have to have your dosage, frequency, and how it's administered. That is one of the key things. And we actually have put that on our intake form. So we adjust our intake forms and put medication, dosage, frequency, and then if not by mouth, please indicate otherwise. That's one of the requirements. And that way we have it, it's documented, it's scanned in the patient's file, and the therapist can easily review that with the patient. And that G-code can now easily be implemented or put on the HCFA form, and I'll show you that at the end. The other G-code that's really easy is the pain assessment, visual analog scales, or maybe the numerical reporting scales as well. And it's a one-time code when billing 97001. If you bill a re-eval, you also need to implement it and put it on there as well for your assessments. One of the interesting things I came across when I was doing some research for the webinar is the pain assessment scale is actually also the Oswestry. So the Oswestry can be a pain assessment and a functional outcome measure G-code. So you're actually killing 2 birds with 1 stone here. And you can, if you just do the Oswestry, now you can document 2 G-code reports for that. So that's kind of a nice thing that I came across the other day. The G-code we use with this is the G8730 code, pain assessment documented in positive. In orthopedics and outpatient orthopedic assessment, we're going to come across that all the time. So we will put that code on there when we do a visual analog scale or the numeric reporting scales. I listed some other ones on here. We don't utilize any of these except for one of them, the G8442. My specialty is vestibular imbalance patients, and they don't have pain. So I can actually put the G8442 code, which is they're not eligible for a pain assessment because they don't have any pain. So not a big deal there. So if you're doing something like vestibular rehab, you can actually use this G code that says, hey, look, I don't have to document. They're not eligible for pain. They just have balance problems. Another code that is interesting is the G8732. This is your get out of jail free card. Oops, I forgot to document. No documentation of pain assessment. If you forget to document, not a big deal. Just use this code, G8732, and that's your get out of jail card free, or get out of jail free card. So the G8732 code can be utilized if your therapist forgets to document pain and they need to add a third G code. Okay. On to the next codes we use is your functional outcome assessment and care plan documented. This is your oswestries, your FAMs, your dashes, your ACES scales for shoulder. So if you're utilizing these, your timed up and go tests, those kind of things are your functional outcome assessments. And that's this code here, and it is used with 97001 and 97002. Interestingly, when I was, again, doing some more research, it said must be recorded on eval in every 30 days. I contacted the APTA yesterday, and they told me it is only utilized when billing 97001 or 97002. So I find it interesting that they wrote it needs to be documented every 30 days when we don't necessarily do a re-eval every 30 days. You know, as we know, a re-eval is only done when there needs to be a change in the plan of care. And if there's not a change in the plan of care, if the patient is progressing exactly as expected, but it might be taking them 45 days to get better, you know, that's a progress report, not a re-eval. We can't bill 97002 with that code. So technically, there's a little bit of, I think, needs a bit more clarification here from the APTA, but the APTA strictly said it's only billed with 97001 or 97002. So you guys will have to make a decision, I think, on your practice if you're going to do it every 30 days or if you're going to just bill it with the two codes listed above. Again, I'm not that concerned about it because we're on claims reporting, and I only have to be accurate 50% of the time. So I know it sounds awful. I know it doesn't sound great, but this is not going to come up. It's going to come up way less than 50% of the time. So I don't have to worry about that gray area of the 30 days or not. And that's the beauty of the claims reporting portion of it. Is that you don't have to be as accurate as if you were with the other ones, with the registry reporting. The fall risk codes, this is obviously my bread and butter here being a vestibular guy. You'll see a lot of these F codes here, and these actually equal one G code. So when you are asking the patient if they have fallen in the past year, that is your 3288F code, fall risk assessment. You have now asked them if they have any balance problems and if they've fallen in the past year. Right there is telling Medicare and telling whoever's looking at this that I asked this question, and that's all these codes are. You know, we probably do this in our everyday practice all day long anyway. Now we're just telling somebody that we actually asked these questions. So you're telling them by reporting this code that, hey, I asked them if they've fallen. And their response is, yeah, I've fallen 2 or more times in the past year. So then now you're reporting the 1100F code, and that's telling them, hey, look, I fell. Look, I asked them. They told me they've fallen 2 or more times. Or maybe they said, no, I haven't fallen 2 or more times. I've only fallen once, and I didn't get hurt. Okay, great. That's the 1101 code. And that tells, again, whoever's looking at this that, hey, look, this was their answer. So that's all these codes are. This is all they're asking us to do, and it's not as difficult when PT Practice Pro and the software has it set up to where you're just check marking these boxes as you ask them these questions, and these codes automatically go on the HCFA form. So really, there isn't any extra work to be done. So let's say you asked them the question. They said, yeah, I fell once and I hurt myself. Okay, well now Medicare's asked us that we have to do a fall plan of care because of that. So because of that, you now have to document the 0518 code saying, hey, look, I did a fall plan of care, which you're going to do anyway because they have a balance problem and they have a fall issue. So now you need to treat that. So 0518 code must always be billed with the 1100 code. Very important to understand that if you aren't billing 0518 with the 1100, then you're going to be out of compliance. And that's, you know, and so that goes against that accuracy reporting. So you go along, you ask the question, have you fallen the past year or two, or the past year, and that question gives you the 3288 code. Yeah, I've fallen twice. That gives you the 1100 code, and then your plan of care, because they've fallen twice, on how you're going to help them is the 0518 code. So right there alone, you just check mark those boxes in the eval, and it'll go along, and I'll show you that. So those are the codes we use in our practice always: the pain, the functional outcomes, the medications, and the fall risk. Those are the only codes we are using in our practice. There is a BMI code, pretty easy one-time reporting. Again, the problem I have with this one is that if the BMI is out of the normal ranges, you have to make a plan of care saying that you either reported them, sent them to a dietitian, physician, back to their doctor, or something to discuss this. And I think most people are going to be out of norms for their BMIs for the most part. So I think it's going to be, it's just not going to be good for the practice. I think you're going to be having to refer people out or talk to people about their diets and that doesn't necessarily fit in for what we wanted to do in our practice. It's completely up to you in your practice, but for us, we just shied away from BMI because of those issues. So how to set up the G codes within the evals, this is where I'm going to show you that. This will be somewhat of a repeat if some of you went to the PQRS course that PT Practice Pro had. But before we did that, we set out as a goal when we heard about the PQRS, and we made some three goals basically we wanted to accomplish with the software. And we wanted to make sure that the software was working for us and that we didn't have to have any increased workload, increased time, and it had to be easy for the therapist. Easy means automatic, basically, for the therapist. We all know that the therapists really are bogged down with paperwork, trying to treat patients. There's more demand on treating more and more patients since reimbursements are going down. And so we have to make sure it's easy on the therapist, and that when it goes to the back office for billing and collection reasons or billing reasons, it has to be easy on them as well. So that was our goals we set out with when we were setting our program up and our evals up for the therapists. So I'm going to go through how we set this up for you and go from there. So let's go here. So basically how we set this up is you'll be in your administration tab, and if you haven't already done this, a lot of you may have already done this, but you go to your administration tab, and right here is your fees. You're going to add, you have to add your G codes first, so you're going to be in your master fee list. And your master fee list is right here, and you can see we've added our G codes, and there's some more down lower, but our G codes are added right here. And it's real easy. You just go into the add new fee, and you can call support if you need help with this. And after they're added into the master fee list, you now need to add them into your fee classes under your account types, which is Medicare. And so that was, again, let me show you, I kind of went fast there. Under fees, fee class, and then you would choose your Medicare. And again, we have it all set up here, and support can go over this with you too. I believe you still have to put a 1 cent as the amount, or it won't read it, and you can see how we have this set up. And again, support will be able to help you with this. So now once it's in the Medicare fee class, now you're going to be able to go into your SOAP documentation and set it up manually. So all you have to do now is go to SOAP templates, and I'm going to show you the balance evaluation. And we have a lot of ours, most of ours is set up under the patient history. And again, you can set it up wherever you want. And these are the questions I ask my patients as I'm talking to them about their falls. And I ask them again, how many falls have they had in the past year? So right there is my my reporting code. And technically, I should have that code of the fall history code, the 3288 here, but I have it down lower. So if I ask the question, and as I'm going through living my falls occurred, last fall occurred, they can tell me 3 months ago and whatnot. So as I'm coming back down, here's my pain scale, and then I ask them what their medications. I talk to them about their medications. Now here's the neat thing. Here it is right here, what I'm showing you here. Here is the medication G code, And that will now automatically add to the HCFA form when I check mark that box. And let me drill down here for you. So basically all it says is medications were reviewed with the patient. And that's what Medicare asks us to do, is review the medications of the patient. They wrote them on the intake form, you reviewed them, you talked to them a little bit about them, and now it shows that. I did do a fall history because I asked if they've fallen in the past year and talked about some living environment stuff. And so now I have the fall history. And they said they fell 2 or more times. Again, I would just be check marking these boxes. And you can see that these G codes are right here. And this is the key, this CPT code. That's how you'll get automatic adding onto your HCFA form when you're doing your claims reporting. You just add that. And I think all you have to do is, I'll click up here. This isn't the proper spot. But if you start typing in G84, there it is right there. So if that was your medication one, you can do that, and then that'll come off of there. And that's how you get that to automatically add into your system. And I'm sure there'll be some questions about that, and I think Karthik and those guys in support can handle most of those questions. Let's see. Let's go back. Okay. So again, it'll make more sense when we go through line item by line item and how the eval is performed when I show that to you. I do want to talk about severity codes briefly. Severity codes is a whole different beast, and there are a lot of different ways we're going to be reporting severity codes. And we are still working. It's still a work in progress for us. In fact, we don't even have them on our evals at this time. And I believe where we're going to be putting them is at the bottom of the evaluation. So when the therapist can see them up front and center, they can say, oh, this person is 19 to whatever it is. I think it's 19 to 30% impaired. They have these funny percentages with the severity codes, and I'm sure once we get it set up, we'll probably do another webinar regarding the severity codes as well, and go from there, because it's a bigger, in my opinion, it's a bigger mess than the PQRS thing was, and it's going to take a lot of training for your staff and therapists to understand why they need to do this as well. So that I think is probably another 30-minute webinar on its own as well. I do want to show you before we finish up here how the G codes show up and how easy it is for your therapists. Let me go to my schedule to tomorrow. So I created a fake patient here, and we're going to, let's say they come in and I'm going to be doing my evaluation with the patient. I personally don't use the template side. I use all the left side here because I have a lot of canned responses for my vestibular imbalance patients. And so as I'm going through, I'm asking about their complaints. They say they're having problems walking and they're off balance and they have a history of falls. I can click on those and I can just minimize. I ask them how many falls they've had in the past year. Let's say they've had 3. So right there alone, there is my G code there. I will ask them, last fall occurred about a month ago. We won't worry about, let's say they live in a single-story home. And they have an assisted device. They use a single-point cane. Here's my visual analog scale. If I want to do that one, I rarely do that one for even for the not appropriate code. I rarely use the visual analog pain scale. But I do review medications with them, and this is where that G code will be entered. By me just check marking this box, the G code will automatically be added to the HCFA form now. So really, there's no extra work for your therapist, and there's really no extra work for anybody in the area. I asked already how many falls, so I did a fall history. Right there is another G code added. They had 2 or more falls. Right there, that adds that other G code. And I am going to be doing a fall plan of care. I already know that, so I'm going to put it there. There's the G code there. And I will do a functional outcome measure. And I just hit add. And my eval comes up, and you will see, let's just come down here, functional outcome assessments plan of care reported. And yes, this does go on your eval. It's really not that big of a deal. You know, some people say, well, do we need the physician to be seeing this as being reported? I actually don't think it's that big of a deal. It doesn't take up a lot of space, and it's just fine. So the physicians don't really care about this side of it. So it will show up on your eval. So when you go to, I think it shows up. So here's your view charges area here. And you can see that all this is going on your HCFA form right now. And we have a total bill of 5 cents because you have to have a dollar amount there. So right there alone, so I just added now, I have my fall plan of care, and I have my 3 G codes that I'm required to have on my eval now. There is a little snag with doing it this way, or you can see I'm getting a warning up here. At least one charge has a missing diagnosis pointer. So your back office or your therapist will have to add a diagnosis, because you'll notice I haven't put a diagnosis in yet for the patient because I'm still evaluating them. Obviously, you know, they're going to have difficulty walking. We'll just put that in as the eval, or as the diagnosis. And so, but there is still, the diagnosis pointers are still missing, and if you don't know what a diagnosis pointer is, that is telling Medicare that this code is being attached to that diagnosis. So, you know, technically you might have a shoulder and a knee person that you're seeing for a shoulder and a knee, and you did, you know, TheraX for 15 minutes on the shoulder, and you might want that just to point to that diagnosis pointer. And then the knee, you might do another TheraX for 15 minutes, and you want that to point to the knee, technically. We don't normally do it that way, but I think that's really how this was created. So because it is missing, because we added the G code prior to having the diagnosis, it's missing it. Your therapist will have to be trained to go up to financial and go to the add charges area, and I don't know why it's not showing. It should be showing. Oh, I bet you my staff didn't set it up, set up the full account. But there is a diagnosis pointer box here, and right in this area here. And all you do is you click on the box, and it shows the diagnosis. It's really straightforward. Some of you probably already have seen it, but it'll be right here for you, and it's quite simple. And then after that, you just hit Save Changes, and it's a done deal. Okay, so that is the real life scenario on how the G codes are added, and you can see they're added automatically, really painless. I only need 50% reporting to be accurate, but overall, this is how we have ours set up, and this is how we've been operating now for the last, I think, 3 months. And really, we've had no issues with the therapists, no issues with the back office. It's been very seamless, and the PT Practice Pro software has made it that way for us. So that is the conclusion of this webinar. I'm trying to see if we have any questions. I'm not seeing anything. Karthik, do you see anything?
Doesn't look like we have any questions yet. Somebody did ask before that if we would be able to provide these slides, and I think that's definitely something we can provide for everyone, right?
Yep. You have the slide. Actually, yeah, you have the slides actually. So
okay.
I actually made some adjustments to them, so I'll send you the updated ones.
So
yeah, and yeah, so the slides will be made available for you guys as well. And so anyway, since we don't have any questions, I guess that would be it.
A couple of them just came in there.
Oh, cool.
So one of them says, can you show us how your eval looks when you hit the print button?
Oh, sure. Okay. So basically, I'll just show you the, this is the history portion. So, oh, you know what? I'm glad you asked that, because one of the other things I forgot to mention was that when you do a functional outcome assessment, Medicare requires that you actually have a plan of care when you do that functional. I'm sorry, when you do when they're positive for the fall risk assessment and you have to do a fall plan of care, the requirements of Medicare is that you review that they had a proper assisted device with them. Or if they didn't, what did you recommend, and what did you do about it, basically. So I have these canned responses here in the plan of care, and this is basically what Medicare requests is patient to benefit from front-wheeled walker, made recommendations to the physician, basically. Patient benefit from power mobility device, and Medicare has these listed exactly like this. That if they need a front-wheeled walker, power mobility, quad-wheeled walker, single-point cane, or any other assisted device. So I have some canned responses in here that they're to benefit. Or maybe right here the patient is utilizing the proper assisted device. You're going to put that in to the plan of care. And then another thing they request is, did you do any treatment with them? And obviously this is, but they want to know that, hey, look, you had a fall plan of care on this treatment. You did some balance training, maybe some gait training, or some strength training with them. And so I have all these canned responses in here, and I utilize them. Maybe this person was using a proper assisted device, and I did some balance training on this treatment. Okay, so I would add those in there. Maybe they needed a front-wheeled walker instead. Maybe they were so off balance they needed a front-wheeled walker and they didn't have one. So you would say, recommend front-wheeled walker, and sent off to the therapist or to the physician for a prescription for a front-wheeled walker, if your state makes you guys do that kind of stuff like ours does. So those are our canned responses, and your state may not require that you need to have a prescription for a front-wheeled walker by a physician. If that's the case, then tweak it for your state, but ours requires that as well. So let me hit print here so we can see this. So basically, this is what it looks like. And so we have our complaints, our falls in the past year, 1 month, and then as you go through the assist device, and here's the things people probably want to know what it looks like. Medications were reviewed, G-code recorded, fall assessment, G-code recorded, 2 or more falls, fall plan of care documented, and then functional outcome assessments. So medications is 1 G-code, functional outcome assessment is 2, and then these 3 here count as 1. So I have my 3 G-codes right there. And this is, obviously there would be objective measures in here as well, but we're just did the patient history and then and then a little bit of the plan of care. So, and then here's that plan of care listed here. Patient utilizing proper assistive device balance training instruction was provided with this treatment. Okay, does that answer that question? And you said there was another one?
It looks like so. The follow-up, there's another question here is, it's my understanding, Nicole asked, it's my understanding that the medication's G-code should be done at re-eval as well. Has this changed?
When we talked with it, they are almost all the codes are done at 97001 and 97002. So you are right if you're doing re-eval. But again, I want to stress that a lot of people, when they do a progress report and there is not a change in the plan of care, if you're still doing strengthening and balance training and you haven't there hasn't been any major change in the plan of care, you are technically not allowed to bill 97002 with that code. And that some people may disagree with me on that, and I've had a lot of conversations with people at PPS regarding this, and that is the overall census, is that if there is not a change in the plan of care, 97002 cannot be billed. A progress report can be written, and then you would probably use the, people are like, well, how am I going to get paid for doing a reassessment on somebody? Well, physical performance test and measure, 99750 is a code that can be utilized for physical performance test and measure. That's when you're doing, tugs, timed up and goes, you're doing some other functional testing on them. You can bill that code then with that. So Only when there's a plan of care change is when you can bill 97002. So yes, if you bill 9702, you will need a Medicaid. You will need to report that, I believe. And I'm looking at this right now, and I may have missed that area. But APTA will be able to be a little more clear, have some clarification on that as well. But my understanding is they're almost always billed when you have to bill 97002 as well. We rarely use that code because there's hardly any major change in performance and in the outcomes or in the plan of care. So with it, but most of them are that way. And I'll clarify for you guys, and I'll get back to you on that. I'll update that slide. I'll contact the APTA today, and I'll update that slide. I don't see my notes here that show that for the 97002 code as well. So anyway, so I'll get back to you guys on that, and I'll update my slide. If you don't see it change, then that'll be the way it is. It'll be the correct way. Any other questions, Karthik? I'm not seeing questions on my side, so.
It's probably because you have to hit the expand button there, but we have one more question, and this is from Kevin here. Kevin asks, how are you handling the discrepancy in units versus the total minutes of care provided, which will be created by the G-codes not having a time linked to it?
Yeah, great question. Yeah, because when you're looking at average units billed, especially when if you're running stats like most offices do, and you're saying, okay, well, this therapist is doing now reporting this huge number of increase in codes in average units billed. I think that's what Kevin's asking is, since we're having three. I mean, when you do the fall outcomes, you could have 5 or 6 codes additional for that eval, and that's going to increase someone's average units billed quite a bit. And so for stat collecting, how are you going to manage that? And so we have started doing 2 things. We are looking at average units billed, but we're also looking at average billed amount as well now, because it's only 1 cent. So it's not going to change our average billed amount that much. So that's one way we are offsetting that. Also, over time, your average units billed, it's all about trends. So if you see a huge uptick in or downtick in changes, you're going to know that something's going wrong with that therapist. Maybe that therapist is only billing 2 units a patient or 1 unit a patient, and why is that kind of thing? I think is the main concern we had, and it really is about trends. And so obviously you're going to have an uptrend right now because you've just implemented these G codes, and then they're going to stabilize, and I can check over the next few weeks or months and see if there'll be a downtick or an uptick in average units based on what they're currently doing now. So that's kind of how we're looking at it, is more trend-like, and not worried so much about the actual number, because we know it's going to be an uptick in it as well. At least for Medicare, it will be. But we're kind of just looking at average units or average amount billed per patient now is kind of where we shifted our eyes now. Did that answer Kevin's question?
Yeah. He had one follow-up question to that, is that he's pointing out that the system will provide a warning to therapists due to an excess units billed versus minutes of treatment. So I believe he's talking about the Medicare 8-minute rule enforcement. And I think the answer to that one is that it's possible to bypass that, but I don't know what your thoughts were on that.
For the 8-minute rule?
Yeah.
Honestly, haven't given it. I don't think we've ever had that problem with that, just because we're billing. I'm not seeing an 8-minute rule warning for those codes. I don't think you check mark it as a timed code in the setup. Let me check here. I think that's what he's asking, right? I think that's what.
Yeah.
So I think when I go into my, is it master or is it, what's it under? Is it master?
It's under master.
Time-based here. So is it time-based? So we don't make it as a time-based code. And I think that eliminates the 8-minute rule.
That's correct. Mm-hmm.
So that gets you out of that there, and then it also doesn't count as a visit. We just left it blank as a visit. So as well.
And just for those of you curious about this, is that Medicare 8-minute rule is being enforced by this screen here, that time-based on a particular fee, and as well as the patient's insurance. As long as that insurance has the property is Medicare, then that billing it will be enforced.
There you go. Okay.
So it looks like that's about it here.
All right.
Todd, well, we absolutely appreciate your time and the effort you spent putting this presentation together. So as I responded to some of the questions, is that we'll try to make these slides and this recorded webinar available to everyone as soon as we can.
And I will clarify the medication thing for you guys on the newest slides. So for you guys. All right. Well, thank you all for attending.
Thank you so much, guys. Thanks.
Yep. Have a good day.